presentation. So yeah, are the slides visible?
Yeah, we can see Sirisha. Go ahead.
Thank you. Secondary glaucomas are those glaucomas where we know that there are secondary causes. It could be developmental, it could be acquired, and there are quite a few of them that we deal with on a day-to-day basis. Why is it important and why this secondary glaucoma is really close to my heart is that in the study that was published from All India Institute, if you look at just the profile of secondary glaucomas, you'll realize that the causes may be variable, but what is very interesting here to note is these are younger patients. They have a male preponderance, most often because they are secondary, they could be unilateral. And more than 50% of these patients, in fact, it's about 63% of the patients have vision less than 2200 at presentation. They have intraocular pressures really, really high, sometimes going beyond. You can see the baseline IOP is more than 30, is beyond 45. So the least number of patients that they have seen is 45%. And as high as up to 78% of them had intraocular pressures beyond 30 millimeters of mercury. And they have very severe disease at presentation. So this just gives you the gist of what the secondary glaucomas are. Unlike the primary glaucomas, where we know that if you diagnose them early and if you're treating them appropriately, we should be able to save vision. These eyes, you can lose vision in less than a month's time. So that is the gravity of the situation. Hence, diagnosing them appropriately is very important for us to treat them well. So we know what typical angle closure looks like. The reason why I'm starting with angle closure is many times there are a lot of masquerades where we would be able to miss secondary glaucomas in these patients. And that's the reason why I'm taking you through this. So typical angle closures, you know, the sphincter changes that happen, sometimes they can be subtle, sometimes they can be quite obvious. You have angle closure, which is most often bilateral. And you can have a typical acute angle closure, which has features that all of us will be able to pick up. When do you suspect a secondary cause? Always, this is an untold finding or an untold sign that if you have an angle closure which is unilateral, always suspect a secondary cause. Having said that, if you have, let's say, bilateral angle closure, can there be secondary? This is something that I can take you through a few examples. A 21-year-old lady presents with very high intraocular pressure in both the eyes. One eye has normal vision, other eye has almost no vision, PL plus in one eye. So this lady has an angle closure which is very unusual for that age and with that high an intraocular pressure. No other posterior segment pathology noted. And we all know that we definitely have to rule out a ciliary body lesion or any kind of a thing that is behind the iris. So gonioscopy will give you some clue, but UBM is very, very important. And this patient has significant disc damage. You can actually see that. UBM showed multiple ciliary cysts all through 360 degrees. So this lady had a secondary angle closure, secondary to the multiple ciliary cysts. So unless you find out a cause, treating them the way we normally treat with a PI and going ahead with the medications is not going to help. So always think of a secondary cause, because what is the situation here that will help you to suspect is the age. At such an young age, is very, very unusual to have a primary angle closure. Another young male presented with unilateral high IOP. Right eye is 48, left eye was 19 millimeters of mercury. Angles significantly close, like a typical angle closure. Yes, male is a little unusual, but it's not that it doesn't happen. And this patient also, like I said, has an asymmetric presentation. So this patient had all features typical of an angle closure. We went ahead and did a YAG peripheral iridotomy, and of course we were following up that patient. Over a period of time, what we noticed is that the PI closed. So always we tell our patients that when we do a PI is patent always, PI doesn't close. If a PI is closing, there is something else that's happening in that area. Patient has developed a peripheral anterior synechia that is actually closed that PI, which means that you're dealing with a disease which is not primary. So this patient over a period of time, PI closed. And as we went by, this patient slowly started developing progressive iris atrophy and ectropion UVA, typical progressive iris atrophy. But this patient actually presented as a primary angle closure with absolutely no iris changes. and changes were there only in the angle. And this patient, fortunately, we also had a specular which we were doing over a period of time because of the young age at presentation and things like that, showed typical features of ICE syndrome. So we had to revisit the diagnosis. This patient had an ICE syndrome. Possibly in the area where we have done a PI, we have triggered a little more of inflammation, and the synechia started developing because of the membrane that had grown from the corneal endothelium. So this patient actually, after all this, required at a later time point, I think 2-3 years later, required a keratoplasty in one eye. So unusual presentation, again, young patient, bilateral, but keep a watch. And findings of a closure of a YAG-PI tells you that there is something else that is secondary and we need to rule out a second cause. A 19-year-old male patient was referred to us with pain, blurring of vision of one eye, in the left eye, and vision was 20/80, IOP was quite high, closed angles with new vessels on the iris. Right eye was essentially normal. If I show you a posterior segment photograph, essentially it is okay, except that in the left eye, if you see, media is slightly hazy because of the high intraocular pressure, and cupping was slightly more compared to the right eye. But otherwise, you don't have a posterior segment pathology that will help you to suspect the cause for the neovascular glaucoma in this patient. So the FFA showed delayed filling, and there were choroidal non-perfusion areas in certain places. The ERG showed reduced oscillatory potentials and also reduced amplitude of both A and B wave. What was a clue that was there right from the day one, but possibly we missed it, is on a dilated examination, you can see a localized cataract here. And this patient over a period of time also showed some amount of fluffy material in the anterior chamber. This patient had a ciliary body mass that was picked up on a UBM. And this patient was very, very unusual. I think this is the first of its case where this was a delayed presentation of a retinoblastoma. So usually medulloepithelioma or a ciliary body tumor is a more common cause, but this patient had an anterior retinoblastoma which also had invaded the ciliary body, and this was the presentation. So localized, so unilateral angle closure, neovascular glaucoma, no posterior segment pathology that you will actually find out, always do a UBM. We should have done a UBM rather than going ahead and doing the other investigation. We can do the other investigations, but the first thing that should come to your mind is a UBM and a careful anterior segment evaluation. Had we picked up that localized cataract, we would have definitely suspected a ciliary body pathology. Bilateral sudden decrease in vision in patients with high intraocular pressure, you can have. This is again not very uncommon, but for the benefit of the audience who are there, I thought I should present this case. Again, a common presentation of a drug-induced angle closure secondary to this sulfur group of drugs that people use. So what are the typical features? Sudden decrease in vision, shallow anterior chamber, very high intraocular pressures, myopic shift in refraction. A patient who was not myopic earlier can actually accept a sudden myopic refractive error now -2, -3, -4, and whatever it is. And these patients typically don't have a disc damage because this is an acute presentation. So always think of a drug-induced cause. How much ever you treat, this is not going to come down with your regular medications. We have to stop the offending drug and put the patient on topical steroids and topical cycloplegics and not do a PI for these patients. What is diagnostic is investigation, which is UBM. So clinically we can make it out. But if you have a facility where you have a UBM, please do it. We will be able to visualize a ciliocoroidal effusion, which is present bilaterally. And think of all the drugs. Commonest drugs are sulfur group of drugs. So apart from the antibiotics, think of the acetazolamide, which is a sulfur group of drug, which we normally use, also can cause this problem. Topiramate is a commonly used drug, which is an anti-migraine drug, anti-epileptic drug. It's like a used for multiple other pathologies by neurologists. So this is a drug that we need to think of. Also, anti-diabetics and anti-hypertensive drugs also can cause this. So think of a drug-induced angle closure when you see such a presentation. Unusual acute angle closure. This is again one of my patients. We were about to do a PI, but before we did a PI, what was very obvious was, you see this blood-tinged hypopyon and a dirty gray color that you can see through the pupillary area. So these are a couple of findings that tell you that there is something unusual. And this patient, when we did a B scan, had an intraocular mass. So typical features of acute angle closure. But if you see hypopyon or fibrin or blood-tinged kind of a hypopyon, or the reflex that you see through the pupil, which is not normal, always think of a secondary cause and do a B scan to rule out a posterior segment pathology. Early postoperative rise in intraocular pressure in patients coming to the emergency again is not uncommon. I just put up a few pictures which are representative. Post-vitreoretinal surgery with oil blocking the pupil in a phakic eye. In a phakic eye, we don't normally, the vitreoretinal surgeons don't do a surgical PI, but this can happen. If you see, this beautifully looks like a crystalline lens, but this is actually an oil bubble blocking the pupil on day one post-op of a patient with post-VR surgery, pupillary block because of a desec and a large air bubble in the anterior chamber, or malignant glaucoma following any of our glaucoma intervention is something that we need to think of. Crystalline lens, which is dislocated or subluxated, a trauma. A commonest cause of unilateral angle closure in a young patient, always think of trauma and a subluxated lens that or a vitreous in the pupillary area that is causing a pupillary block. One more case, again, a young patient was referred for a YAG PI, again unilateral angle closure, but just see the eye, it is so congested and the patient had severe pain. Patient was actually started on pilocarpine and referred to us for a YAG PI. A B scan and ultrasound biomicroscopy will help you to understand. Patient had thickening of the sclera and a posterior B scan showed a posterior segment elevated lesion, and we dilated the patient, did not do a PI, and you can see a huge mass sitting there at the posterior segment. This patient also had, you can see the hypertensive retinopathy changes. Patient actually had COX and was a very, very high hypertensive, and patient had to be started on medication. So don't do a PI. You may actually be dealing with a life-threatening situation and you could be the first to diagnose a condition here. When you have an open angle, when do you suspect secondary open angle glaucoma? Majority of the time, the features are very typical. So you have a trauma, you could have a history of steroid use, you could have multiple other things, post-surgical, these are the things that we think about. So I wanted to share a couple of cases which were very, very, for me, it was something that I learned from these patients and hence I wanted to share. A 17-year-old girl studying 12th standard, this was a year ago, was preparing to be a doctor. She complained of headache and blurring of vision, and she was, as usual, told that she was overexerting and because of which she had this headache, and said, okay, take an opinion from an eye specialist. So she came to me and her vision in the right eye was 20/40, left eye had less vision and pressures were very high. So the first thing that will come to your mind with no other pathology, no history of use of drugs, no nothing, is a juvenile open angle glaucoma. And while we were asking a couple of more questions, they just asked her, are you using any skin cream? She said, not much, but I just use one cream that I use at night, and I've been using that for the past 2-3 months. Because of a lack of sleep, I'm developing these black eyes, and hence the doctor, somebody advised her to use this medication. She was using a cream like this. When I went up on the internet and checked if there was a steroid content in this, there was actually nothing, and in these contents that tells you that there is a steroid. Okay, this looks so innocuous and there is absolutely no problem. But I was not happy with it. I went back and re-looked at what was there. I'll come to that, what was there in that drug. And one more patient similar to this, a 21-year-old who's an engineering student, came similar kind of findings, and he was using another cream called Pfizer Care Cream, which again is a beauty cream. And when you go back and look at the contents, there is absolutely no mention of the steroids. But this particular one is actually banned in Pakistan when I went and reviewed the literature. And the first cream also, the pearl cream that I showed you, as well as the second cream, I'm just giving you names because these are looking so innocuous. So unless we know that it's a betnovite or some kind of a skin cream where you have a steroid in its content, we suspect a steroid-induced glaucoma. But beware that none of these creams that are available today, if you see the contents, don't be happy with it. Go back and check. And when I checked this particular drug, this pearl cream was intimated by the Dermatology Association to the drug controller. They checked, they found high contents of steroid in it, and they have actually filed a case in the court. Despite that, this is a picture that I took yesterday, and this is available on the internet. Anybody can buy it. So in India, I think we need to be very, very careful about the fact that we have lots of these drugs that are available in the market. Many of the young people are losing eyesight because of this. So we need to be very, very careful. First of all, understand the cause and try to treat it, but we need to take it up to the higher authorities to try and ban these drugs permanently that are available in the market. So the other group of patients that we typically have secondary glaucomas, which we may be losing eyes, is post-cataract surgery. This is an example I wanted to share because there was a lot of discussion going on in the glaucoma group recently. about multifocal IOL. The patient who had a multifocal IOL in the bag had lot of pigment dispersion and had very high intraocular pressures, and they were not understanding why this was happening, and this patient was referred to us. If you just see, this is a multifocal high magnification view. This is in the bag I'm talking about, but one area there was a irregular rhexis with a fusion of the rhexis margins with the tilt of the edge of the intraocular lens, and that was causing rubbing of the posterior surface of the iris with pigment dispersion. Okay, this patient required a IOL explantation, and we had to place a 3-piece lens in the bag, and post that her pressure started coming down. So why I wanted to share this is that just because we have an IOL in the bag, it doesn't mean that this complication cannot happen. Although rare, we have published this, but this can happen, especially if the edge of the intraocular lens is tilted, especially if you have fusion of the capsular bag, and that tilted square edge designed lens can cause pigment dispersion, and that can cause uncontrolled intraocular pressure, and that needs to be treated appropriately. So they can present variedly. You can have an obvious tilt like this. You can have a broken intraocular lens placed in the sulcus that can cause pigment dispersion, which was explanted. And this patient, again, you can see if a small portion of the haptic was broken, we shouldn't take a chance. We always have to make sure that this is taken care of. Otherwise, we may end up having to replace the lens at a later time point. Another situation, this is again a very interesting case of ours that we were treating. This patient had again in the bag intraocular lens, a Sion type of a design lens that was placed many years ago. Patient came 10 years later saying that patient had a decrease in vision and recurrent redness. This patient was treated as uveitis in our institute, but this patient would come back again and again. Inflammation comes down, you put them on steroids, anti-glaucoma medications. So this process was repeating for a couple of months. When one of the cornea consultants decided that we need to take an opinion and we need to see why this is recurrently happening. So when I did a good gonio for this patient, I don't know if it is clear, but you can actually see blood in the angle. So what had happened was the rhexis was intact, but the equator of the lens had broken and the haptic of the lens had gone through the equator and was eroding on the ciliary body area. And on a dilated gonioscopy, you can actually see blood in the inferior angle. So we need to pick up the reasons whenever something like this is happening. And this patient actually needs clipping off of that haptic. Otherwise, this is going to be recurrent and we may lose the eye in a period of time. Same way, many times people say that, okay, there was a small tear in the rhexis. I don't think that's much of an issue. A hydrophobic intraocular lens is placed in the bag and your haptics are aligned well, there is no issue. But if it is placed in the sulcus, beware, you may not see a problem now, but it will come back to you or may go back to someone else many years later. So this can happen as early as in a month post-surgery, or it can happen many years after surgery, where we may actually be losing the vision for the patient slowly. And if this happens in a glaucoma patient, one needs to be even more careful. And so this is a sulcus placed lens. So what is the property of this intraocular lens that causes this problem is something that I thought I should share. So you see, this is a very sticky lens. Instead of sticking to the capsule when it is placed in the bag, it sticks to the iris when it is placed in the sulcus. So this is again a beautifully done rhexis because of a small pupil in an angle closure glaucoma patient one night. Somebody had placed this lens in the sulcus. You can actually see this is a sulcus placed lens. On retroillumination, you can see a beautiful rhexis. Uncontrolled intraocular pressure, patient was referred for a trap. All we had to do was went and opened up the bag and placed the lens in the bag, and now pressures are controlled medically only. So we need to be careful about these. So they can present in a various ways and at various time points. Could be tilt, decentration, excessive mobility, reversed position, multiple things. What are the signs that tell you that this patient has had no PC rent I'm talking about is basically excess pigmentation in the angle and iris chafing that you can see on retroillumination. Why does this happen? Because of the square edge design. To prevent the edge glare, these edges, if you see, are very rough. And that is the reason why this particular problem can happen. A 3-piece intraocular lens is something that can be used in these patients. So it is definitely a serious issue, and careful in the bag placement is very important. Avoid placing hydrophobic lenses in the sulcus. If you have to place it, use a 3-piece intraocular lens, because the 3-piece intraocular lens has a posterior angulation of 10 degree that will prevent its contact with the posterior surface of the iris. Plus the rounded proline haptics that are there are less damaging to the posterior surface of the iris. That is why we use a 3-piece intraocular lens. It could be a foldable one or a non-foldable one, but whatever it is, don't use a square edge design lens in hydrophobic lenses in the sulcus. So the status of the management, again, I'm not going to the details, but they depend upon how early it is. If it is very early, just by placing the lens in the bag or exchanging it would help. If it is at a later date, all these may not help. One may require to do a glaucoma surgery. So to summarize, secondary glaucomas are not uncommon. They can be sight threatening and somebody can lose the eye in a very short time. What is very important is detailed history. Meticulous history taking is very, very important. Sometimes we may need to probe and take history, and meticulous clinical examination. Sometimes we may not be able to diagnose it at first visit. We may need to see the patient back second time, third time by the time you actually come to a diagnosis. Ascertain a cause and treat it appropriately. When in doubt, always do a gonioscopy. Gonioscopy is of course mandatory. Do a UBM and B scan when indicated. Think of common conditions and treat them appropriately. Sometimes we may need to think out of the box, and we may have to deal with the uncommon causes and treat them appropriately. Thank you for your attention.